And good afternoon, everyone, and welcome to the second day of Reach Asia Forum. And for those who newly joined us today, let me have a very brief overview and introduction of the forum. And next slide. And Tavi, next slide. Yeah. And so the goals of this forum, the two-day forum, are to provide a platform for us to share community engagement efforts in Asia. We also hope to stimulate ideas and inspiration of how community engagement strategies can be strengthened and adapt to different cultural contexts. And throughout the two-day forum, we are delighted to have attendees joining us from about 19 different countries and regions. We have 290 attendees who registered this webinar, who will join us or have already joined us at different time points. Thank you very much for being here. For this afternoon's public session, we will hear from 3 experts and explore practical strategies in community engagement, including co-design strategies, risk communication, and more. After this, the invited attendees will also join further group discussion to design activities in our regional hubs. I hope you will all enjoy the Day 2 forum, and also a special thank to our event team for their hard work in preparing for this event. And over to you, Atavi.
Thank you, Yiyun. Before we begin the expert talks, please take note that participants are encouraged to engage via the chat or submit their questions in the Q&A tab. Due to time constraints, we may not be able to address every question during the session, but experts are encouraged to provide answers directly in the Q&A tab. Our first talk for the day will be by Dr. Rainer Tan. Dr. Rainer Tan is an assistant professor at the NUS Saw Swee Hock School of Public Health and is affiliated at the Center for Behavioral and Implementation Sciences, Interventions at the NUS School of Medicine and Center for Family and Population Research at the NUS Faculty of Arts and Social Sciences. In the community, he leads the research work group at the Greenhouse Community Services, a charity providing trauma-informed substance use recovery, is a broad member at Project X, which serves sex workers in Singapore, and a co-lead at SG Mental Health Matters to spur public engagement in mental health policymaking. He's also a member of the Ministry of Health Agency for Care Effectiveness Consumer Panel. It is my great pleasure to welcome Dr. Rainer, whose work bridges behavioral science, implementation research, and community advocacy in shaping inclusive public health responses. Over to you, Rainer.
Thanks so much, Atavi. Thank you, Dr. Yiyun, for the very warm introduction to the talks today, and also for the very kind introduction to myself. Let me just share my screen real quick. Okay, I think this is working here. I see a nod there. So really very privileged to be part of the talks today. So I just want to thank the organizing team for having me, and thank all of you for being here today. And so the title of my talk is Strategies to Co-Create Public Engagement Campaigns with Diverse Stakeholders. And I guess 2 things. One thing is maybe the term like co-create might be familiar to some of you. Some of you might also think of other terms you might be familiar with that's kind of similar to co-create that you might use more in your own setting, but I'll come to that in a while. I also kind of wanted to sort of, instead of saying communities, right? I think diverse stakeholders is something that I kind of want to maybe talk a little bit more about. I also am cognizant that maybe some contexts we are moving away from the word stakeholders because there's some kind of historical element to it that has a negative connotation as well. So, one thing that I hope to also convey through this talk also is just to think about what are the terminologies that we tend to use when we are trying to think about community engagement or public engagement in science. And, I think how does context shape some of these things? And how does context also shape power structures and hierarchies that have led to us in the ways that, we currently do our own public engagement work or even research work. So that's generally the overview of the talk. To do so, first, maybe I'll just talk about co-creation. What exactly is it And why do we do it? If you have some thoughts on the why we do it in your own context, I would love to hear them. But maybe one thing that I would just jump straight in is what exactly is co-creation, right? And one thing that I do realize doing work in this area is that the terminology for participatory work, for public engagement, community engagement, co-creation, they all tend to be quite a lot, right? It's really just this is from Sabrina the Teenage Witch. It is different. Sometimes it feels like that. Like when you are doing the research or the work, there's all these terms and what do they mean? And I think one of the things to also recognize is that many of these terms have been coined and have had some power driven behind it based on the fields that it has come from, right? So citizen science has traditionally come from places like biology, like the weather, where, initially, people were able to contribute to a broader understanding of some of these phenomena, natural phenomena. It's also started to be used in like sociology, to indicate this mobilization of community resources. Community-based participatory research, I think tends to be used a lot in health, patient advocacy, and PPI, patient and public involvement, is something that I'm hearing a lot more. And to my knowledge, it's also a term that's used largely in the UK because PPI is part of the grant terminology. It's stuff that you have to include in your research grant applications, in your reporting. If you're publishing in a British medical journal, for example, a PPI is something that you need to include as a part of your writing there. So do all these actually mean different things, right? I think the field, like many fields where there are so many passionate people, involved, it suffers from a few things, right? I think that's something where I see a lot of people are also trying to gather and consolidate. So there's this idea of homonymy, which is the same term has multiple meanings across maybe different contexts. There's synonymy, where different terms used have the same meaning, or they might have some overlaps in terms of alignment, and instability. For some of these terms, perhaps the ways that we have interpreted them have changed over time. So I think it's very timely that there's a lot more focus, and I speak from the Singaporean perspective, right? There's a lot more focus on patient engagement, getting lived experience at the table, but also how do we then have that conversation with different contexts and make sure that we're talking about the same thing. But not to worry, I think I'm here to sort of maybe distill what the principles are, despite the many terms that you will see, right? And I think when it comes to public engagement and deepening engagement, something that it has been written about by many different fields. I think one thing that many different fields try to do is also to sort of like, how do we conceptualize this and how do we measure this? And when you think about deepening engagement, this is but one of the many different frameworks out there that help to structure what it means, right? So this is published by, I believe, the Clinical Trials Community Engagement Key Function Committee by the National Institutes of Health in the United States about, I think, 14 or 15 years ago. And they have conceptualized deepening engagement through these two dimensions, right? I think a few dimensions rather, community involvement, its impact, the trust and communication flows. So it goes from outreach, where perhaps you're just informing people, it's very unilateral and it's information flows. There's some community involvement, perhaps even just very single directional in terms of the flow of information without any clarification. And entities coexist. Whereas on the other end of the spectrum, we might be looking at things like shared leadership. And what does this mean? Maybe strong bi-directional relationships. It might be multi-partite relationships. It's not just two parties involved. Final decision making is at the community level. And I'm going to sort of also contest that in a while, right? I think there's something to think about when we think about co-creation. So let's put a pin on that in a bit. I think one thing that's also clear is that there are strong partnership structures, as well as the outcomes of the particular activity or research impacts everyone in a mutually beneficial way. I think that's something that characterizes something that's more of a shared leadership in terms of whatever activities you plan. In general, I guess this is what I sort of consolidated and see from the different terminologies out there. There are ways to look at this from a paradigm or like a framework or an approach, basically something that is broader of a process, right? And, some people have written about it. They call it maybe CBPR, community-based participatory research. So it's sort of like a overarching philosophy, right? That actually shapes the way that we do our research, and not just research, but I also wanted to broaden that today, right? That's why when I say research, it's something perhaps most of us are doing, but we should look beyond research also in terms of public engagement. And something that happens and is happening right now is I think more supranational organizations like the WHO have also started to weigh in on what does it mean to be more publicly engaged, more community engaged. And so I think in 2024, there was sort of a resolution passed on social participation in health. And one thing that I like about that is because it does not limit things to research, but it still helps you conceptualize things within a particular scope in health specifically. Something that maybe some of you might be familiar with if you're doing some forms of research would be transformative paradigms. So, we've got qualitative research, we've got quantitative research. Transformative paradigms, suggest that there is some form of transformation that happens as part of the research process. So, it's kind of like a critique of research, right? That oftentimes the research products we stop when we get to journal articles. But what aspect of it does it transform the entire research landscape or the current context that you're working in? And many within these different paradigms, I would see that these different methods are all just different tools and approaches, right? That we can actually conduct the research that we're doing. Or I would say it's not even just research, but with citizen science, there's also a lot of policy advocacy or policy change involved too. And when we think about the overarching principles, what exactly are we talking about in terms of, regardless of the method, regardless of the approach? Some scholars have also written about what these principles are. They include things around reciprocal co-learning, mutual ownership of the shared enterprise or the shared outputs, and also shared decision making. So within these three principles, what are some of the assumptions here? So once we start thinking about these principles, I think it's important to have principles to then guide our objectives and the ways that we intentionally set things up in terms of what we do, not just for research, but for maybe community movements altogether, right? So when we think about co-learning and reciprocal transfer of expertise, sometimes I get this question from the community, what does co-learning mean? When we go to maybe like a community advisory group, or maybe when we go to a traditional research structure, it's oftentimes about just learning about what the project is. It's like one way. You're teaching me how to do research. You're teaching me about research literacy. There hasn't been too much opportunity to do co-learning. And I think what this particular principle is about is about recognizing diverse expertise, right? When we come to a particular co-creation setting, understanding that it's not just about having communities lead. And I'm saying this also because, and it might be a bit controversial, but I think in the last 5 to 10 years, there have been a lot of movements and very well intentioned to actually just place the responsibility and the power in the public, or in communities. But sometimes when we do that without intentionally thinking about building capacity. And sometimes it's not about building capacity for communities, but also ensuring that the capacity is also there to be, to guide everyone else, right? I think when we actually bring everyone to the table, recognizing that they're experts by expertise, but also experts by experience, we can then sort of start to think about what kind of platform or structure for co-creation is the most effective, right? I think it is, even for one thing that I also like to share is even for researchers like myself, I'm also a patient, right? I'm also part of different communities. But when I bring myself to a particular co-creation activity or structure, what hat am I wearing, and what kinds of experiences or perspectives am I empowered to share and to actually help with the decision-making process? I think that's something that is worth thinking about. A lot about co-creation is not just about the structures, but also the ways that we facilitate some of these different aspects of it. The second principle is about shared decision-making power. And I think shared decision-making power is something that is often said, but deserves some time to think about in terms of facilitation. I think many people have also been writing about this, perhaps in clinical settings. What does shared decision-making mean between a clinician and a patient? But have we thought about this through maybe a co-creation lens? And maybe a bit specific to the research part would be mutual ownership of the processes and products of the research enterprise. But if we were to expand this, we can think about mutual ownership of the processes and products, and thinking about what impact means for everyone, right? Not just based on research alone. So I'm going to move on to the next bit, which talks a little bit about the shared decision-making aspect. Something that I, have been very influenced by in my own training, both in like community mobilization as well as in actually political sociology, is this book, or is this article by Thong and Wright. And they talk about, they call it a different thing once again, right? They talk about empowered participatory governance. But I think it's not health specific, but they really looked at how in very participatory kind of activities and programs, what are the secret ingredients? What are the active ingredients that make them successful? And the one thing that I wanted to focus on here is when they discuss this phrase, reasoned deliberation, and what they talk about is this quote over here. They are participatory because they rely upon the commitment and capacities of ordinary people to make sensible decisions through reasoned deliberation, and are empowered because they attempt to tie action to discussion. So you can see some echoes of the different principles there. And one thing that I also, at least from my experience as well, working with being part of community groups and all, is that when we come to the table with shared expertise or diverse expertise, sometimes it's also recognizing that as researchers we bring to the table our research expertise. As policymakers, we bring to the table policy expertise. And so therefore, I also find it a little bit unfair to say that communities have the burden to lead and make the final decisions. And because when we think about community, it should be everyone based on their own expertise as well. And I think one thing to do is that oftentimes we decenter and do not privilege community perspectives, people with lived experiences. And basically, it's not to say that there should be some kind of like equal weightage to everyone. But that's to say also is, looking at your context, looking at your own issue, how disempowered and how much disadvantaged or marginalized are the different people in the co-creation groups that you have, or in these co-creation structures that you have, and making sure that the structures are attentive to these forms of power hierarchies and structures, I think is something to think about, right? To make sure that there's some form of reasoned deliberation where everyone's expertise and lived experience gets to shine at the table, and to make sure that everyone is working towards shared goals, not just the goals set by research grants, not just the goals set by by, for example, certain funders, right? I think it has to be reasoned and deliberated to make sure there's impact for everyone. Okay, so I'm going on to that's more like co-creation. I'm going to skip a little bit of the why, because I'm pretty sure you've heard a lot about the whys we should do like public engagement and like community engagement throughout the past 2 days, right? And I think I can chat more about it if you want after this. But how, right? What exactly do we do for co-creation? This is a bit of a sneak peek, for a co-creation practical guide by SESH Global, UNICEF, TDR, CHI, Social Innovation Health Initiative. And the only thing that I wanted to kind of give you a sneak preview of was something that I was had the privilege of participating back in one of the workshops, which is kind of developing what are the different steps of co-creation. Right. And this was actually informed by a systematic review, by like a co-creation process in itself, involving many different people. And if you think about co-creation in health, it is about firstly scoping things out, identifying the communities that you're working with, making sure that there's a co-creation structure. So this particular guide was focused on youth, but I believe that it can be more generalized. And if you think about all these different steps here, I think being attentive, identifying the communities that you're working with, being attentive to really about, what exactly are the power structures, what are some of the challenges, and then developing a structure that helps you make sure that co-creation can be meaningful is a very big part of the whole process, right? Steps 1 to 3. Once you have the structure there, you can then think about the different tools that you can use for co-creation. And then after that, one thing that I also love about this is that it doesn't stop there. It doesn't say research publications or like something to that effect, right? I think it's about iteratively looking at the process, developing, monitoring, evaluating processes and outputs that are meaningful to everyone, and thinking about outputs that are meaningful to everyone as well. So I'm going to show you some details or some examples later, just to highlight this point. When we think a little bit about something that shapes everything also is when you look at social media engagement strategies or public engagement strategies, they are based on, let's say, social media dissemination. Other scholars have written about this. This is one example on infectious diseases, how to use social media for infectious diseases. And, these are the different, I guess, concepts that you want to kind of adhere to. So they should be eye-catching, they're visual, they're interactive, they're respectful, they are adaptive and they evolve based on needs. And they make learning fun and engaging. And this is one thing that I also realize is when you look at this, and if you think about the structure for co-creation, if we are co-creating things like public messaging, we are co-creating things like social media strategies, when you have diverse expertise at the table, expertise by people's attained professional expertise, but also expertise by people's experiences. I think you would then be able to have something that resonates with people, something that is respectful, and something that is also adaptive to people's needs if your feedback loops are meaningfully closed, right? So by having that structure itself, all these things actually naturally fall into place too. And when you think about, okay, so I've talked enough about like co-creation as a process, so what exactly can you do for co-creation, right? That whole thing was a setup to also think about, when we think about the structure, and we think about the tools that we use, I think it's important to consider these three questions, right? I think the first one would be, what do we co-create? What exactly is the scope of this entire project or this entire movement? What is the end goal? Who should we? I think that really is the important first step, right? The second one would be, once we know all these things, I think we need to then know who is involved. How inclusive is this? Whose perspectives matter? And when it comes to that, because you have multiple structures, multiple tools, you can then decide, whose perspectives gets to shine at each of these different approaches. The last one is how deep. I think later on you'll see some of these different tools that go into different forms of depth in terms of lived experience. How much perspective is shared, and I think these are some of the three questions that you might think of when you're considering which tools. So the first one that I've had the privilege of also being part of some projects is the idea of crowdsourcing, right? So crowdsourcing is seen as a participatory or co-creation kind of approach. This particular article, later you hear from Professor Joseph Tucker, who wrote this article here, but crowdsourcing activities can involve open calls or challenges where you get a call for solving a particular health problem, and you might actually get lots of different submissions across a wide geography, wider context. And you have multiple people submitting their own ideas on how to solve a public health solution, or something similar to that effect. We also have things like designathons. Some of you might call it hackathons, and these tend to be sort of open, sprint-like events. So sometimes they take place over one day, typically over 2 to 3 days, where people start to get together. You might be intentional in the types of groups that you set up, with different expertise at the table. And throughout 2 to 3 days, you provide mentorship, you provide some kind of prompts, you provide meaningful facilitation to solve a particular problem. You can start to see that there are different levels of inclusiveness based on different types of measures, right? So for example, open calls, they might be more inclusive in the terms of like getting more broader participation from different backgrounds, different settings, because of the typical traditional barriers to participation, right? These tend to be perhaps online, or they can be part of a particular community. Whereas the sprint-like event, you might be more intentional in who you select or who participates, because the goal is to develop a more in-depth solution, that takes maybe about 2 to 3 days to develop, with multiple diverse perspectives. And there's also open call crowdsourcing approaches that use digital systems that for example, if you know about like Yelp, about some of these review platforms, like those are also ways of like crowdsourcing information, right? And when you translate that into health, you can also have people help map out certain kinds of services, or access to some forms of services as well. If you are considering more of these, you can also check out like crowdsourcing open call guides. These are some practical guides that are published by the World Health Organization, in collaboration with some of the partner organizations, on how you can actually use some of these tools to conduct co-creation types of activities. these are just some examples that I will skip through in the interest of time, but we've done some online that has involved a global community. And this particular one, we actually were looking for open call for submissions by youth innovators so that we can identify youth innovators around the world. And also the prize or the recognition will be to link them up to mentorship structures. Participatory designathons and hackathons, there's also a practical guide out there. So I won't go into too much detail, but you can also start to see that there are many different ways that you can involve and co-create solutions, that are not just top-down or based on maybe a theory that a researcher puts out there. More recently, like this is a picture of my team. We did a hackathon or designathon that's focused on addressing HIV stigma in Singapore. And we actually had multiple groups drive and think of a solution on how we can work on HIV stigma. And now we're working with the winning group on co-creating an intervention, that we can pilot test and develop some science around. And I will go into more detail, but there's not too much time. But there was quite a bit involved in terms of the mentorship, the facilitation, and making sure that everyone had the right tools that they needed to run this designathon. These are some other, there are many papers out there that, look at community engagement techniques and approaches, but you can start to see when we think about co-creation and, who should be involved, to what extent, to what depth, the entire process opens itself up to many different tools, like all the way from in-depth interviews, which, some people might argue are not like formally community engagement or public engagement, but I feel that in the spectrum of things they are, it's just that, they tend to be very one-directional kinds of information elicitation. But you can start to see from there all the way to the other end of the spectrum. There are many different tools that you can utilize to also engage communities, engage the public, and think about what kinds of perspectives should be there and who should be there at the decision-making table as well. So here are some different examples, like co-creation groups. So sometimes you don't need a designathon, you don't need an open call, but you rather work with a solid a group of people, something like a community advisory group, right? But I think co-creation groups tend to be more focused on one particular activity or one particular aspect of maybe research or a program. And for example, we did co-creation groups where we sort of put people together, something like through a consultancy to recognize people's expertise. Is diverse, people with experience, people with different trial experiences, people with some kind of a scholarly experience in terms of theory. And we developed through this trial in China postcards, and also the trial protocols for this particular randomized controlled trial. This is one example. This is another example from a crowdsourcing open call. So if you're looking at community-driven kinds of outputs, perhaps for a social media strategy or even to drive certain forms of access to some kinds of like health interventions, this particular study involved actually crowdsourcing these forms of media to drive HIV testing among men who have sex with men in China. They did a step wedge control trial, and one thing that they found was that the community-driven posters actually were more effective than expert top-down kinds of approaches as the standard of care. It's in PLOS Medicine, I believe, and you can look it up. I'm sure we'll share the slides later on. There's also been ways to sort of keep people engaged, right? So this is maybe about HIV pre-exposure prophylaxis adherence. And, when we think about reminders, we might think about text messages, but if you bring that to another level, how do we make things more resonate? How do we make things resonate more with people that are more based on their own context? And co-creation can also lead to some of these different types of outputs, and they can help with not just maybe engagement with clinical trial participants, but you can imagine that if we co-create with the public, we could also definitely develop content that resonates with the wider public as well. But all this also depends on what your co-creation activity is and who should be involved in that whole process. And you could also even co-create through a designathon, right? So this designathon that was held in Australia on HIV pre-exposure prophylaxis, the winning group, I believe, came up with the idea of doing a podcast. And so the research team supported them, to try and drive public education of this particular HIV specific innovation. And I think this was evaluated later on in the trial, that you can find the link over here below. And lastly, one more example would be here in Singapore. I think this is not really research specific, but it was more a national strategy to drive suicide prevention in Singapore. It was a ground-up approach. It was called Project Hyatt. You can actually find out more. But I think we sort of neatly structured it based on three different parts, right? There's the structure, the co-creation structure. There are the tools that we use, and also in terms of the different accountability mechanisms. So in terms of the structure, we made sure that the working group, the strategic group, was diverse, included people with lived experiences. We delegate the empowerment to different representatives from the working group as well, who are driving different subgroups. And then we had a multi-methods approach to research that also involved people with lived experience. Right. So I think you can find out more in terms of methodology, but basically the working group shaped the research approach and also shaped the ways in which we measure impact. So I can tell you that it started out in like 2024. It's been about close to 2023. It's been close to 2 years, but actually we haven't had a single research paper out yet because we've been privileging a lot of reports that were directed to policymakers, and this has appeared in the news. We are now working with the National Mental Health Office in Singapore to really translate some of the research. But this is the most meaningful thing to people on the working group and people with lived experience, right? Not the research articles, but the kind of policy impact that we can actually make that is more timely to focus on right now. Yeah, and I think the last bit here, I just wanted to reiterate some points that when we're doing co-creation, one thing that we often might be tied into conventionally is thinking about impact through, let's say, research publications and so on. But looking beyond academic impact is important. What is the social impact? How many times has your research been mentioned in Parliament? How many times has your research been mentioned in the news as a public engagement strategies? How are public involved in the process? Doing a process evaluation of all these different aspects is equally important to actually having the research out there. Because implementation science will tell you that research takes about 17 years, for it to translate into actually guidelines and policies. And so, I think equally focusing on the parts that are not just traditional measures of academic impact would be important. There are papers out there that show you how some of these process evaluation aspects are done from a research perspective, in terms of research publications. But I won't go into too much detail here in terms of time. And if you're thinking about, say, some of the crowdsourcing approaches, there are also ways, like I don't see these two things as mutually exclusive. You can do all these activities with a focus on, output that drives change in the community. But also at the same time, think about how you can convert them into research articles and as well. So this is where that whole deliberation process and making sure that we do not privilege one perspective over another is important. Then you can actually meet different goals at the same time. Okay, I'm going to stop here in the interest of time, but I'm happy to share more later on during the panel and hopefully in the breakout rooms too. Thank you so much for your time.
Okay, thank you, Dr. Rayner, for the engaging talk and for reminding us that we are both contributors and recipients of research. Now, may I please introduce Dr. Margaret, who will be our second expert speaker for the day. Dr. Margaret Harris, who was born in Australia but now lives in Hong Kong, has spent most of her working life as a global health risk communicator dealing with outbreaks and emergencies in Asia, Africa, and Europe. She first trained to be a medical doctor, but then became a journalist, working as a foreign correspondent in Europe and Asia for the Sydney Morning Herald, Melbourne Age, and later medical editor for the South China Morning Post. During the 2003 SARS outbreak in Hong Kong, she wrote a daily column providing information about the protective strategies and behaviors people needed to adopt. And it was then she decided to study global public health at the School of Public Health, University of Sydney, to apply the skills she had developed working as both a doctor and a journalist. Since then, Dr. Margaret has spent most of her time working in risk communication for the World Health Organization and UNICEF, mostly in Asia, Africa, and Europe. including the Western African Ebola outbreak in 2014 to 2016, the Korean MERS outbreak, the global Zika virus outbreak, and the 2018 to 2020 Ebola outbreak in Eastern Republic of Congo. When the COVID-19 pandemic emerged, Dr. Harris was called to Geneva to act as a global spokesperson for COVID-19 and remained as a global spokesperson until retiring from WHO in 2025. She now works as a global health consultant. I'm honored to welcome Dr. Margaret, whose career has shaped global risk communication across multiple public health emergencies. Over to you, Dr. Margaret.
Thank you very much, and thank you very much for those kind words. And I should have mentioned in my bio that I sent to you that my final term when I did my medical degree was actually with the National University of Singapore. I was based at Kadang Kabau Hospital. And so it's very nice to be back with you all at the NUS. And I really also appreciate the previous speaker, because many of the messages and many of the things you said really resonate with my experience, as well as what I'd like to talk to you about today. And indeed, I'm looking at what we've learned from trying to communicate risk to populations. And I mentioned the West African Ebola outbreak, particularly because that's where we really learned that you cannot do risk communication unless you are engaging with the communities you think you're speaking to. So we now actually call risk communication community engagement. We have this long acronym RCCE. Anyway, first of all, I should just start with a definition. What is risk communication? Lots of people think it's just putting up a nice poster. And in a sense, that's how it first developed. It became a discipline really when the tobacco industry was so good at marketing its products, the only product that you can legally buy that's guaranteed to kill you. And the health community had to find a way to communicate that this is a risk that you don't want to be taking and what actions you should be taking to prevent that risk. But it's really important, and this has come through very clearly with the previous presentation. It's a real-time exchange of information and advice and opinions between experts, community, or leaders. It's not top down. It's not the person, the Margaret Harris or anybody else telling people what to do. That won't work. It's got to be an exchange of information. And it's got to be a catalyst for behavior change. Effective risk communication is done so that people in risk can understand what their risks are and adopt protective behaviors. So again, it's not just about messaging, it's about making things actionable, ensuring that what is the basic risk, that people understand what their basic risk is, but they can actually do something about it. There's no point in saying, get vaccinated if you don't have the vaccine available, if you don't have the vaccine centers, if it's not acceptable, the way in which you're doing it to the people you're advising to do. And it's really important for authorities as well. It's an educative process of authorities, again, that they understand what are the concerns and needs of the people that that are at risk, but the authorities need to know what the needs of the people are and that the advice provided is relevant, trusted, and acceptable. There we are. And so, yeah, I've already sort of mentioned previously, really, why does it fail? And it fails a lot. We saw in COVID-19 a lot of failure of risk communication. Quite often it's applied poorly or too late due to lack of preparation. That's like not knowing who your community is. And we've seen a really great description of how to identify who is in your community and ensure that they really are participating. So lack of preparation, like limited capacity, not putting the effort in to reach people or to understand what people's needs are and what ensure that action really can be taken. Lack of funding, that's always the case, or inappropriate funding. You may have a funder who wants to do one thing, but really it needs a lot of other things need to be done differently. So you just being driven by a funder who says, no, I only want this, can be a problem. lack of recognition that's an essential part of a response. That again, it's often sort of, oh, nice, and we'll have some community engagement, we'll have a bit of risk communication, as if it's a bit of window dressing. It's not. It's absolutely fundamental to success, and failure to recognize that it's a two-way process. Not enough listening and learning is much more important, really, than speaking or messaging. And then all of these things lead to loss of trust. And once you've lost trust in your community, doesn't matter what you do, don't know how clever you are, how lovely your posters are, how much effort you make, it's really, really hard to get back from that. I probably, this is not so relevant because this is a research forum, but it's important, again, just as part of the evolution. Why did it become important? It's become recognized that over and over again, if you want to do any kind of medical intervention, you want to do any kind of medical research, if you are not communicating effectively to people about why this is important to them, why they need to do this, why they want to do this, it will fail. And it's now been incorporated in the International Health Regulations, which is a core document for the World Health Organization for responding to any kind of health threat. And it really became clear. I think we'll all remember, well, maybe some of you are too young, but I remember well the 2003 SARS coronavirus outbreak, which prompted this revision of the International Health Regulations and it incorporated risk communication. Now, okay, so I've moved into this horrible picture I've given you. I'm sorry. It's a bit early in the morning for me even. What the next thing that really happened, and we saw a real failure of risk communication and community engagement, was the West African Ebola outbreak. There was wrong messaging, and again, it was very top-down messaging. It wasn't messaging that recognized the needs, the understanding, with no participation of the community. And this messaging was given out in Guinea at the beginning of the Ebola outbreak in March 2014. It was messaging that had been used in previous Ebola outbreaks, but it was basically a bad case of dusting off the messaging. And the messaging was, Ebola is a deadly disease. There is no treatment. Come to the treatment center. First of all, that doesn't make a lot of sense to anyone. I don't think I would. But also, in the context was, in Guinea, they'd had 30 years of terrible, terrible, terrible war. And they'd had many of the communities had the experience of government authorities, government groups turning up in their village, rounding everybody up, putting them on trucks, and those people never came back. And then we have the West African Ebola outbreak. People came to the village, this time in the white suits like this, rounded everybody up, put them on trucks, and they never came back. And then also, it was even more mysterious because of these white suits, because of these treatment centers. Nobody was allowed in. Nobody could understand what was going on. Community were given no information. So what happened? People stopped identifying any Ebola, any possible Ebola cases in their village. They stopped telling the authorities about anything going on. The infection went underground. And the responders dealing with the outbreak were like, oh, great, we fixed it, all good. Because again, there was not that community connection. There was not that community communication. And so the Ebola outbreak went underground, crossed over into Sierra Leone and Liberia, and exploded in Sierra Leone in May 2014. Not only did it explode in Sierra Leone, 2 months later, it had gone to many other countries, including the United States, that had their own limited Ebola outbreak. And we saw outbreaks in Spain, in Italy. So from that communication failure, we saw a massive explosion of one of the deadliest infectious diseases known to mankind. This is why it was recognized you need to get it right. I worked as mentioned, and when I got to Sierra Leone, it was very clear that people did not have information. They needed advice about protective behaviors. Their knowledge of the disease was was all over the place. All sorts of rumors were raging. a misinformation epidemic was raging. It was really my first experience of trying to combat a misinformation epidemic. Now, at the same time, we learned that there was a potential vaccine. This had been sitting in the Department of Defense in the US since 2012, and it was possible to do a clinical trial. We got to the stage where we could do this human safety trials, phase 2, we could, and then move into phase 3 very quickly. Now, it was very difficult to get anybody to be the principal investigators. WHO ended up doing it as doing the field research ourselves, because the partners who would normally do it just really weren't willing to do something so dangerous, especially in Guinea, where where community engagement teams had actually been killed because the population was so angry and so anxious about what was going on. So this is where community engagement became so critical, because the testing, the phase 3 was something that was a real challenge, not just in terms of field work, but also in terms of ethics, because you have this deadly disease, 90% lethality. You have a vaccine that could well be highly protective. We don't know. We have to do the phase 3 testing to be sure, but is it ethical to have a control group as well as an intervention group? So the decision was made to randomize villages with known outbreaks to either getting the vaccine initially on day 1 or day 21, because it's a 21-day infectious cycle. But also, in order to be able to do this research, it was critical to do good community engagement and risk communication prior to starting the trial. And that did happen. And I think, I'm trying to remember the numbers, but I think more than 70 villages were randomized. And it became pretty clear very quickly that those villages that got the vaccine day 1 were protected. Those who got it day 21 had cases of Ebola. So the trial was stopped, but then it also continued to move over to Sierra Leone, where I was working. And one of the things that was really advantageous in terms of risk communication was I had been a volunteer for the human safety trials for this vaccine. So I could say that I had had the vaccine and here I am. And that was actually extremely helpful. The people in the community could talk to me and ask me, blah, 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 but also had trusted me. I suppose it's good that they believed, but it was true. I had the vaccine, but they trusted me because I was willing to take the vaccine. We saw the same thing in the MERS outbreak, not the same thing, it was a different thing, but again, it was a failure of risk communication that augmented the spread of MERS. So once again, getting it right is critical. And the failure of risk communication was that the messaging was, again, top-down. Government said, you do this, did not listen to the people. The people did not trust. They did lots of doctor shopping when the same patient went to 2 or 3 different hospitals and doctors, and that's how it spread very, very widely. So because we had all this huge amount of learning very rapidly through all the different outbreaks that we were working on at the World Health Organization, we decided to do a systematic review of the evidence of what really works. And this is drawn from outbreaks of the last decade. This is published in 2017. It's definitely due for an update because it needs an update from the huge amounts of learning that we've had from the COVID-19 outbreak. But essentially, we found 3 big sort of themes: building trust and engaging with affected populations, integrating emergency risk communications into health emergency responses, not so relevant to this group, but absolutely critical, but applying evidence to planning, monitoring, messaging to communication challenges, and having a continual feedback loop. I really liked what I saw in the previous presentation about how you continue to evaluate. You don't just say, oh, I've done a really good job, here it is, off we go. If you're not evaluating and continuing to evaluate, you're going to fail. And one of the crucial things is building trust. As I said, once you've lost trust, game over. When you have any kind of risk communication, it's got to be linked to functioning and accessible services. And so this is where, if you don't understand your community, if you do not understand the people that you're trying to reach and what's important to them, you will fail, because you will not be providing functioning and accessible services that they want to use. It doesn't matter what you say, it's not useful. And you need to be transparent, timely, and easy to understand. I should have put also accurate, truthful, and clearly truthful. I think transparent is the term there. There is this kind of belief that you're going to market to make people want to do a thing. You must be truthful. You must acknowledge uncertainty when you don't know. And with an evolving outbreak, like say COVID-19, and I could point to quite a few mistakes that were made with the risk communication by WHO, and many of the mistakes that were made were failure to acknowledge uncertainty. Address the affected populations, know who they are. That's the previous presentation identified that very clearly. Know who they are, who is important, who needs to be spoken to, and who needs your information. Link to self-efficacy. Make it possible for those who are receiving your message to actually do something, do it effectively, and want to do it. And don't, identify the blockers. You may think, oh yes, come to the treatment center, come to get vaccinated. But if you're not providing toilets in the vaccination center, many of your groups, particularly your elderly, won't be willing to come. And disseminate, use multiple populations, again, methods and channels. And you need to know what methods and channels people are using, what's important to them. And so you need to know who you're trying to reach, and you need to know your groups. We've had a much better presentation on engaging communities. As I said, this is meant to be risk communication, but we don't do risk communication without community engagement anymore. And again, we found that if you're working to engage with communities, you have to identify who the community trusts and build relations with them. And it's not necessarily, the leaders. Traditionally, you go to a village and you find the head man, usually man, person, and speak to them. But they may not be the person the community trusts, or the issue that you're working on may not be something that he or she is interested in. You may need to speak to the women. You may need to speak to the older women. You may need to speak to the youth. It depends on what your issue is, and involve them in the decision-making. And we saw very well in the previous presentation how you do that. And if you're not involving them in the decision-making early on, and ensure that the interventions are collaborative, contextually appropriate, and community-owned, you're going to fail. So here's some of the evidence that we found again, that planning must occur well in advance. Risk communication interventions need to be rapidly evaluated, and those findings used to inform and improve the response. I found over and over again, this is the bit that's often missing, that really listening to what's going on and understanding you're getting it wrong, and changing and correcting your course as quickly as possible. And media and both social media and traditional media should be part of an integrated strategy, because you need to achieve conversions of verified, accurate information. If you're hearing something, the same sort of thing from 2 or 3 channels, most people will think, well, sounds like that's accurate. Sounds like that's correct. Now, messaging is always a problem, because again, we often come down very top down, very scientific, and risk should not be explained in technical terms like numbers or percentages, like you've got a 30% risk of this, 40%. That's not helpful. Tell people what the problem is and what they can do about it. And consistency in messages, as I mentioned in the previous slide, is absolutely critical. And this to me is the most important thing. Messages need to promote specific actions that people can realistically take to protect their health. The idea of risk communication is to achieve agency, that people can use the health information, the information you're providing to protect their own health and make their own decisions and do things that will help them achieve good health, or protect them from whatever the health threat is. So messages should be pre-tested if you can, to ensure that they are culturally acceptable wherever possible. So again, what we saw on the previous slide is critical to this, knowing who's there, working, co-creating the messages to ensure that they are culturally acceptable and work. And they should be reviewed and reshaped as the emergency evolves. Just a few last tips. Again, this is kind of like the risk communication Bible. Be first, be fast, and be frequent with the information, but also admit what you currently know and what you don't know. That's what I mean by acknowledging uncertainty. Be honest about what you don't know, but what you're going to do about it. So just don't say, I don't know. Say like, we are doing this, this, and this to understand this area is still uncertain, but we're doing this, this, and this to understand. Give very practical, actionable advice. Choose a trusted spokesperson. This is critical. We saw very much during COVID-19, the politicians all wanted to be in there. And quite often that was when some of them ended up being very trusted communicators, but quite often they were not trusted and problems occurred, or they gave terrible advice sometimes. So generally, the research indicates those who are trusted as scientists, so most of you are scientists, so that's good news, doctors, teachers, not politicians. Build your links, build them before, build them, continue to build them. Listen, just listen rather than talk. And practice with risk communication, doing exercises, or working with communities, understanding where the gaps are is really important. And I think I've mentioned all this before. Don't just use a bunch of posters that you used for the last activity or try to adapt them. That you will fail. Don't just focus resources on mass media. You speak to your community, listen to your community, and don't just recycle messages. And constantly, if there's any message, and it came through very strongly in the previous presentation, listen, learn from the community rather than come in thinking you know it all. So I'll stop there in the interest of time, and happy to take any questions if that's appropriate.
Thank you, Dr. Margaret, for that presentation. Ian, would you like to ask some questions to Dr. Margaret?
Yes, thank you so much, Dr. Harris, for the insightful talk. And we still have a couple of minutes to go through some questions, and welcome the audience to ask any question if you have. So for me, actually, I have one question from your talk. So nowadays, people are receiving information from all sources. It's not just information from the public health authorities. And I also believe there's a term called infodemics introduced by WHO. So in such kind of setting with people receiving all the information, do you have any tips and ideas you can recommend the researchers and the health authorities how to communicate with public despite there's so much information out there?
Indeed, that's the million-dollar question. We found what we did was we really expanded our social listening. So one of the good things about the fact that now most people, vast numbers of people are using social media, means that you actually have a better way to try to listen to what is important to them. So even though it sounds like there's a massive amount of noise, if you do it systematically, and what we would daily identify themes, and we were looking particularly for areas of misinformation to understand, do we need to then get out there and provide an alternative view? And we did do this very much. We worked with all the different digital companies during the COVID-19, that the various platforms were really helpful in terms of partnerships. So when we needed to get something out quickly, they got it out as quickly as possible for us, which was a big advantage that enabled us to reach a very large global community. But you have to be listening at all levels. The other thing we identified is when you've got massive misinformation. You will have some groups in the middle who will be affected by the extremists, but unfortunately, when you've got the most extreme groups, you're not going to be able to change that because they're really sitting in almost closed echo chambers listening to each other. So we found we had to focus on the groups in the middle who might be influenced by the more extreme groups and bring them back to a more reasonable position. So it does require a lot of energy, but it also requires knowing that you must listen first and then respond, but you also have to be quick. But in some ways, the fact that there are so many platforms, it makes it easier to be quick than ever before. Because before, you're going house to house and holding town hall meetings. But now, to an extent, you can at least reach people a bit more quickly. Although I'm not sure that you can reach them in the sort of the really engaging. As I'm personally, I'm old-fashioned. I like talking to people individually. But I think at least you can reach larger numbers of people. So social media, in some ways, has made community engagement more effective.
Thank you. Thank you very much for the answer, and definitely respectful and social listening to the community is very important. We also have other questions from the audience, but in the interest of time, we will carry some of the questions to the panel discussion. And over to you, Atavi. Thank you again, Dr. Harris, for your talk.
Thank you, Dr. Margaret, for sharing such an insightful talk grounded in your experiences. Finally, our third and final talk will be by Prof. Joe Tucker. Prof. Tucker is an infectious diseases physician and social scientist with a special interest in pro-social interventions that focus on community benefit. He is a professor of medicine at the University of North Carolina and a professor of global health at the London School of Hygiene and Tropical Medicine. He chairs the WHO Guideline Development Group on multiplex testing and supports the WHO on participatory research as part of SEHISH, Social Engagement to Spur Health. It's a privilege to welcome Professor Tucker, whose work focuses on using social engagement to improve health at the community and global level. Over to you, Prof. Tucker.
Thanks. Thanks so much. Can you see my screen and hear me okay?
Yes,
Great.
all good.
Okay. Thanks for the kind introduction and really great series that I'm honored to join today. I'm gonna talk about nourishing communities, a broader menu of community engagement strategies for medical researchers. And my son is 13, and for him, like a great meal is the Tesco meal deal. You can see on the right, it's like simple. It's like got all these terrible, like addictive foods, and he loves like junk food, right? But couldn't we, for almost the same amount of money, you could get amazing food in Singapore in many cities. There's like Michelin-starred restaurants dotted all over the place that are like street food, right? And I think this talk is really going to think about how we can, what's a broader menu of community engagement strategies that we might want to consider when we're running a clinical trial or doing some other medical or public health research. So I'll talk a little bit about community engagement. I'll talk about some different strategies on the menu. And then finally, I'll end with a few open access resources and tips. And on the right here, you can see two Nigerian early career researchers, Yusuf Abatunde and Korede Adedeji. They basically went to Geneva last year and marched up and said, "Hey, we want more youth co-creation." A lot of the things that you just heard from Dr. Tan, they said, "We need, more of this. We need more youth agency. We need more co-creation processes." And the WHO, to their credit, they said, "Yeah, you're right, we do." And I'll tell you a little bit about their story too along the way. So this is a quote Tell me what you eat, and I will tell you what you are. There's sort of an interesting relationship between food and social fabrics and community, and I'm gonna unpack that a little bit in this talk. So, what is community engagement? You've heard other definitions. This is the WHO definition from a couple years back, a process of developing relationships that enable stakeholders to work together to address health issues and promote well-being to achieve positive health impact and outcomes. So notice this is really about relationships, and I think you've heard from several of the speakers already today, like relationships are so important in community engagement that it's not something in a vacuum, and even in the digital environment, it's still very much bound up in relationships and dyadic and network kind of relationships. On the right here, you can see a few participatory activities from our SESH group. On the upper part, this is a design-a-thon, a participatory event that brought people together into small groups. And this is actually where Yusuf and Korede marched out from to go to Geneva and say that we need more youth co-creation. So now I want to just take a moment. The chat has been um, enabled, so you should be able to actually write directly into the chat box. What community engagement strategies nourish our communities? And by communities here, like end users, researchers, policymakers. You can go ahead and write into the chat box, not the Q&A, the chat box. I'm curious what people think here. What are nourishing community engagement strategies? Tarvi, can you check to make sure the chat is open?
Yes, the chat is working.
Okay, thanks. Genuine dialogue. Yeah, understanding lived experience. That's great. I completely agree. Um, Engaging communities from the beginning. Definitely. I think a lot of communities feel left out if their involvement is midway through or at the very end. Um, Engaging all stakeholders, so being inclusive about stakeholder engagement. That's fantastic. I agree. Listening, as Margaret just mentioned before, and as we heard from Rainer earlier too, this is really important. Spending enough time with people. Yeah, we're so time impoverished. So just like being there, like when you're talking to someone, really fully 100% being there, spending time with people. I like that. Patient-led, so listening to patients. It's a great way to think about it. Focus group discussion, so like research. How can we use research to nourish communities? I like that too, Audrey. Yeah, yeah. Ensuring that all age groups are heard. So thinking about inclusion of younger people and older people, as many societies age, I think it's a very important consideration. And building in sort of accommodations so that older people are able to contribute or participate. Iteration and engagement. Yeah. Um, Great. Well, you've got a lot of excellent ideas, and we'll come back to this. We'll come back to this at the end, and reflect a little bit more. Um, so. All right. So the broader menu. What's on the menu of community engagement? Here are the bits that I'm going to talk about. I'll talk about starters, and by starters here, sort of something to prepare for research, something that's done early in the research life cycle. Condiments, something that you might sprinkle, a little pepper, a little salt that you could sprinkle on top of research, a side dish, a vegetable that you feel like you need to put in there, but maybe not loved by everyone. The main course. So what's a core component of an intervention to be tested? something that's not community engagement just because it's a tick box, but really like thinking about research that's focused on participation, where the hypothesis involves greater or lesser participation or engagement. And really, this is like thinking much more about a rich, umami bursting feast. And then finally, because I'm sure we have a few sweet tooths in the audience, dessert. Like, how do we sweeten our research? How do we make it so that it's not just a medicine pill to be swallowed? All right, so starters. You've gotten a research grant, or maybe you're at the research, you're writing a grant proposal, and you want to get some sort of rapid feedback. And starters are sort of these kinds of things could directly inform grant applications. In the British parlance, it's called PPIE, patient patient and public involvement and engagement. It's sort of a long acronym, but really it's community engagement. And then community accountability. So a lot of these types of activities can make it so that so that there's a sort of an accountability mechanism. So uh, and then how do you do this? In our research team, there's a great restaurant called The Shoom here in London. And we've many times before, we'll just invite people who are sort of end users to a Dishoom brunch. If it's about pregnant women and vaccines, we might ask 5 or 10 women who recently had kids to join us for a Dishoom lunch. And that's a really kind of simple way to get feedback, to take time to listen to each other, and for the community members to kind of better understand what we're thinking about, and for us as researchers to better understand what end users or local people might think about the work. And then, as Rainer just mentioned, co-creation groups, it could be very simple, two researchers, two end users, iteratively discussing a topic. Um, And then, so a condiment, what could be sprinkled on research? These are very short kind of things that could be helpful to enhance end user perspectives on research. Low budget, it's often very simple. They're design sprints that could just be a few hours with a diverse group of people and clear objectives. There are also events that are sort of shorter than designathons, what we've called mini designathons, where it's along the same time scale. It's even shorter where it's like, 90 minutes. And these are alternative sort of formats and structures that one might consider in terms of community engagement. What are the side dishes? There are lots of things that could be required and provide structured input and are relatively inexpensive. You've already heard about community advisory groups, where sort of end users provide advice on information, informed consent tools, related materials. Um, and then the other thing that can be useful is to actually have a person with lived experience as a co-applicant or a co-investigator. So in other words, it's having a paid member of the research team with lived experience. And for some UK grants, this is actually required. Like the funder would come back and say, hey, you have to have a PPIE co-applicant because of the nature of the participatory research that you're doing. And then main, main course, like, what is this? What would this look like if we took this to its logical conclusion? Um, I think you've heard a little bit from Rainer already about open calls and sort of challenge contests. This is where communities develop ideas in response to a challenge. There are also designathons, this like three-step process that's informed by design thinking, and then co-creation where you have iteration and small group works, with attention to power imbalances. So I think for me, there's a lot of exciting methods, not just these. I mean, I mention these because these are ones that we've had more experience with, but there's a whole bunch of related participatory methods that are really exciting and I think are pushing the boundaries and making us rethink the relationship between people and researchers. So, dessert, how do we sweeten our research? Increased participation could enhance implementation. We've used an approach that we call pay it forward, where a person comes into a clinic, they'll get a free service like a free test or a free vaccine, along with a handwritten postcard encouraging them to get tested. And then if they choose to receive the test or the vaccine, we ask them, would they like to donate money or to contribute in some other way to support others to get the same service? And this is part of a broader umbrella of pro-social strategies, like thinking about contributing to others, helping others. And I think this is increasingly, if we want to have communities engaged in our studies for our research purposes, we need to think much more clearly about what is the benefit to communities and how could we do something as a partnership that's not just like, oh, this is a research study, but think about it from a community perspective. Um, there are a lot of unanswered questions. We need to do more research on a whole bunch of different fronts. So, how can we meaningfully engage communities in simple ways that matter to their lives? What are ethical ways of community engagement across a research study? How can we best measure community engagement? And then finally, how can community engagement spur social change? How can this move the needle on issues that are important to communities? There are a bunch of open access resources. You've probably heard of GPP before, Good Participatory Practice. This was produced by UNAIDS and AVAC a few years ago. And then within the WHO, there's a special program called TDR that has published a number of different sort of normative guides related to crowdsourcing and public engagement. There's one that's the text has been approved for co-creation and keep your eyes peeled. There'll be a practical guide coming out probably in January or February in the early new year focused on youth co-creation. And that's actually the sort of end point of Yusuf and Kureide's journey that I mentioned at the beginning. So they ended up contributing and really co-leading and playing an impressive role in developing this practical guide. So summary points, a simple shared meal can be a low risk way to have communities better understand your research and you better understand your community partners. And community engagement really provides a number of like tasty recipes, ingredients, shared tools that can transform your Tesco meal deal into something more interesting and nourishing. So I encourage all of you to invite communities into your grant applications, your implementation, your dissemination. It's really a time-honored recipe for research success. And so now we'll open up the chat box again and go back. What is one spoonful or ingredient you will take from this talk and bring back to your community engagement? What are things that resonated with you or little bites that you think might be relevant to your work? Great. So getting a few ideas. Food is the pathway to brain power and collaboration. I'm sure the foodies in the audience would agree. And it can be simple, it doesn't, even a meal can be difficult to organize or find someone, but, breaking bread or maybe in the local cultural tradition, maybe doing something like that can be helpful. Um, and community engagement can be bite-sized and is not always necessary to have a multi-course meal. Yes, I completely agree with you. It's in some ways we think about engagement as like something that needs to be done, but it's rare that we think about what's the right size of engagement. Like, is it too little or is it too much? Um, and the earlier that we can get our communities, start talking to our communities even at the stage of like writing a grant application, the more likely that we'll be able to bring in those same people later and sort of report back and work with communities throughout the whole course of a research study. Um, I saw several folks said, yes, pay it forward, pay it forward. We like that dessert. Um, and I think, yeah, and the pay it forward concept doesn't necessarily need to be money either. Even if there's already a free service that's available, it could be more of a gift it forward, um, arrangement where there's a group that, you have people volunteering as peer navigators or people writing messages to each other, some other non-monetary way that people could contribute to a to a research study. Um, Other thoughts about are there other um, things that resonate? Um, Great. Well, these are great ideas. And so the final slide here, I'd like to thank the Reach Asia Forum, um, Dr. Mo Yin, Dr. Rainer Tan, Dr. Bebe Xiong, and the Advanced ID team. It's just looking at the lineup of talks that you guys have organized here, it's really exciting. And I think this is a really important event, and community engagement as a concept, I think, has really just taken off. And there's a lot more research that we need to do, more thinking and engagement. So this is really exciting. Um, I'd also like to thank our SESH team, CHI, um, and if anyone is interested in chatting, feel free to reach out, email me, or send me a WeChat. Yeah, happy to answer any questions, and I think we have a few minutes left.
Thank you so much, Prof. Tucker, and your encouraging words for the community engagement team. Over to you, Ian, for questions, please.
And thanks very much, Professor Tucker, for the amazing talk and introduce us a very delicious menu of community engagement. And so while we are waiting for questions from the audience, and I do have a question. So for the different stages of community engagement in health research, um, like if we are going to implement in clinical trial and research, what kind of challenges do you think researchers may experience in this process?
Yeah, thanks, Sho. It's a great question. And I often find that there's a big kind of gap between clinical researchers or physician scientists and like the community. a lot of my physician scientist colleagues, they're not used to the cadence and rhythms of community engagement, or they see community engagement as something that could potentially be interesting, but it's like they've spent years, like, they've often spent like 2 or 3 or 4 or 5, 6 years to get an idea funded, right? So they've been like working, working, working to get it funded. They finally get the grant, and then the ask is like, oh, wait, could you do some more community engagement that would lengthen the time to like launch their trial and potentially like interfere with, the main comparisons or what they're doing. So, like from their perspective, I see how this is really, it's like it's potentially disruptive. But I would say there's often a mantra in community engagement, and we've heard this already today, that like, oh, if you don't start with the same people early, that, it's too late to go back and later do community engagement as part of research dissemination. But I would push back against that. And in many ways, like focusing more on the latter part of a clinical trial where here's the paper, you know, you've just got your paper in press at like Nature Medicine. How, if I go back to that same physician scientist and I say, hey, what if I get young people or your study participants to like, really carefully create infographics and videos and enhance dissemination, then it's a very different discussion. Like it doesn't slow anything down. If anything, it accelerates the impact of their research. Like the many of the beneficiaries, they have skills and talents and wisdom that are relevant to this. So it could be a very different discussion. So I guess my advice would be to talk with your clinical trialists, your trial colleagues early. Think about the later stages of research, more like dissemination, as a sort of an entry point, and sort of iterate. But yeah, it's a great question. Thanks, Sha.
Thank you very much for the answer. Um, I following up with this question, and we all understand it's very important for the trialists and for the doctors to realize importance of this process, not just think this is just something to tick the box or other things. But we also see the trialists and also doctors, they also sometimes have very limited time and energy to do this. So, what kind of tips and recommendation are you going to give them if they only have limited time and resources to do the community engagement in their research?
Yeah, it's a great question. Um, And I would say for a trialist who's never done community engagement before, it's probably more like the sides, like getting a community advisory board, having some kind of structured mechanism where their clinical trial could have community engagement. And because I think there's also a myth, like a trialist would need to realize that it's going to take time and it's going to take money to do it well. So like if they're not doing this at the grant writing stage and actually putting into the budget like money for PPIE or money for community engagement, then in some ways it's too late to go to them once the trial is enrolling, or once the plan is cooked, the protocol's already finished. I think it requires like going a little bit like in terms of the planning process, like planning at the grant application stage would be really important to kind of carve out both the budget for your activities and also um, the time required. And I guess the other part of this is like for a lot of physician scientists or health professionals, they see the patients who benefit from community engagement. They know them on a first name basis, right? So like pulling in some of the like physicians' lived experience as health providers and like, you know, helping people who are sick, I feel like that relationship and some of those clinical relationships, that's probably like that's something like an entry point or a way to kind of um, to remind clinicians about the importance of lived experience and like these personal relationships. I think that might be a more useful way of framing it or thinking about it.
Thank you. I think like planning ahead is quite important. So we actually had a question from the audience. And so the question is how to mitigate challenges in stakeholder engagement when policymaker representatives change very frequently. So do you have any experience to share?
Yeah, this is a great question. Because this is inevitable, right? Like the person who's the Minister of Health or the person responsible for this part of a health bureau is those they're often going to change. Like sort of by definition, there'll be people who leave and people who come, and I would say like the relationships at the end of the day, like people are going to continue to serve the communities that they're really passionate about. And if someone leaves the Ministry of Health and joins like you know, say a pharmaceutical company or maybe they do a PhD, it's not like a loss for you, or it's not that you're working with that person is less useful. It's still at the end of the day, it's like these relationships between people that are really important. And whether someone's in academia or you know, the public sector, the private sector, I feel like they'll be able to wield influence, and we need champions in all these different sectors to kind of push forward health and push forward community engagement. Um, I see another question. Do we have time for one more, show, or do we need to run
Uh,
here?
Thanks for the answer. I think in the
Type
interest of
it.
time, yes, we possibly need to move on to the next section.